Okay, it is 10 a.m. Hello, everyone, and thank you for joining ED Care today for this continuing education presentation. My name is Erin Benner, and I just have a couple of housekeeping announcements for us before we get started. And for those of you who are not familiar with ED Care, we offer eating disorder treatment in Denver, Colorado Springs, Kansas City, and in Omaha. We are in network with over 35 insurances, including TRICARE and Medicaid. And we also offer free confidential assessments. And if you have any questions about programs at ED Care, I have my contact information put in the chat. And please feel free to reach out to me and I will do my best to answer any questions that you have. So don't hesitate to reach out. And then today's presentation is approved by APA and NBCC to offer one continuing education credit. ED Care maintains the sole responsibility for all aspects of this program and its content. To receive credit, you must attend the full live webinar, and at the end, an evaluation will pop up on your screen. Please fill this out and as well ensure that you indicate whether or not you need a continuing education certificate. If you don't, let us know you need one. We won't send you one. So please make sure that you indicate that, and we'll process your certificates within about a week and email them to the email that you used to register for this webinar. And the webinar will be recorded and emailed to everybody by early next week. We'll also save about 10 minutes at the end of today's presentation for questions. You can send in your questions using the Q&A function on the panel at the bottom of your screen. So this will should be the bottom middle. The bottom middle two Q&A chat bubbles is what they look like. We'll do our best to get to as many questions as we can at the end of the presentation. And without further ado, I would like to introduce Dr. Tamara Pryor, who will be presenting Temperament-Informed Treatment for Eating Disorders. Dr. Pryor has worked in the field of eating disorders for the past 30 years and has spent the past 16 with ED Care, where she currently serves as the Executive Clinical Director and Director of Clinical Research. Dr. Pryor conducts research and has published articles examining personality disorders, substance abuse, multi-impulse behavior, sexual functioning, and cognitive rigidity in the eating disordered individual. And she has presented nationally and internationally and co-authored a preventative curriculum and textbook, as well as co-authored 3 chapters in a textbook on eating disorders and substance abuse. Dr. Pryor is a founding member of the Eating Disorder Research Society, a fellow of the Academy of Eating Disorders, and serves on the board of directors of the National Eating Disorders Association. So thank you so much, Dr. Pryor, for being here to present today, and I will hand it over to you.
Thank you very much. And thank you, ED Care, for sponsoring this. And for all of you that are taking a little bit of time out of a Friday morning to spend time with me talking about an area that I've been interested in, quite frankly, since the 1990s, in terms of understanding. First of all, my research started out in personality and personality disorders as they were related to different subtypes of eating disorders. And then that kind of morphed into looking at temperament and character and trying to find a way to best understand the temperament and character of individuals that develop eating disorders, and how to use that to then create a treatment plan and shape the work to be done in their efforts to recover. So I certainly wish I could see your faces. I am a speaker that's pretty dependent on finding a few smiles in the audience. I would like to start with acknowledging that certainly I am not inventing the wheel with regards to looking at temperament within the context of conceptualizing eating disorders. So I would like to acknowledge Dr. Laura Hill, Dr. Christina Ruega, Dr. Stephanie Peck, Dr. Walter Kay, Heather Hauer, and then my own research collaborative group that I spent 11 years with, that is the Brain Research Lab of Dr. Guido Frank. All of these people have informed me in terms of my work in understanding and using temperament and character to do psychotherapy and try to engage patients in their journey and share that, join them in their journey to recovery. I'd like to give a shout out to a book that's soon to be published in November 2021. And this is by the UCSD group, as well as Dr. Laura Hill, and it's Temperament-Based Therapy with Supports for Anorexia, a Novel Treatment. And then from our own group, the Brain Research Lab, this is one example of our use of the temperament character inventory, along with the fMRI studies that we're doing. Just an example of some of the one of the many publications that is referencing temperament. So why temperament-based treatment? As I said, we've been interested in understanding temperament and how characteristics of an individual's temperament may in some way influence the development of an eating disorder, or even this maintenance of an eating disorder. But this is different. This is taking what we're learning from our neurobiological studies, from understanding the genetics of eating disorders, and then what we understand about the individual who develops an eating disorder with regards to their temperament and character. We're taking that, and Dr. Laura Hill and Dr. Walter Kay together with several other members are taking this and then creating an actual treatment. The treatments we've had that are evidence-based in the field of eating disorders have primarily been CBT, CBTE, and IPT. So this is exciting. This is exciting to think that there might be a new form of treatment that can help us feel more effective and be more effective in treating our patients. So we do know that traits such as perfectionism, anxiety, inhibition, and hyper-vigilance are often viewed as vulnerabilities to develop an eating disorder. Substantial research to support that. We also know that many who recover from eating disorders actually tend to do quite well in life. They achieve academic honors, they seem to have a competitive advantage in certain professions, and we may wonder, why is this? So what we're theorizing, and I think what we are observing in our work, is that within certain context, these traits that may have made the individual vulnerable to develop an eating disorder can serve as assets. Self-discipline, organization, attention to detail, all of those can certainly serve as assets within certain contexts of life. So what is happening within our field, and what many of my colleagues are working on, is that we're trying to shift our understanding of trait-based risk for the development of eating disorder to more of a dual consideration of how these traits, yes, they are vulnerabilities, but they can also be strengths. And this is so, I think this is so positive in our field, because so often our patients come in and they feel broken, and we're focusing on what's broken and the psychopathology of eating disorders. So to really have a model of treatment that can be more strength-based, I think is something which is akin to positive psychology. It can really give our patients so much more hope for the future. These stable traits, these hardwired traits, can be harnessed not just within treatment, but I think it is important to look at how to do that within the context of treatment. But we will also want to teach our patients how to harness them and use them outside of treatment, because of course that's going to promote long-term success. Time and time again, we have patients that do very, very well within the structure of program, but then the minute they step out of program, then they don't know how to do life. They don't know how to translate what they've learned within the program, the structure of the program. So we think that this harnessing these traits and applying it more to real life will really relate to recovery and sustained recovery. So what is temperament-based therapy? I'm not going to spend a lot of time on this. I would recommend you to Laura Hill's TED Talk for those of you that are kind of just coming into consideration of whether or not this would be something that would be valuable to you and your practice. But I will give you a little brief overview of what you're going to read when you buy her new book. So the TBT philosophy is based on the belief that personality traits can range from destructive to productive expressions, originating from genetic, neurobiological responses, and then shaped by environmental influences. So this is something we've known when prior to working with temperament-based treatment and temperament character inventory, I was looking at personality, and when I would sit down and do personality testing review with my patients, I would start out with saying, everybody has a personality. It's not right or wrong, it's not good or bad, but what we do know is certain characteristics of your personality will be exacerbated during stress, during illness. And that's what we want to look at in terms of how can your personality work for you and how can it work against you during the course of very difficult situations, life situations. Now, the core tenets of TBT are: number one, eating disorders are biologically based disorders. I don't think there's any questioning of that anymore. The research is so very, very solid in that regard. The idea of the clinical work that you're going to be doing is you're going to treat to the trait. And I'll talk a little bit more about that as we go along. This has been in our field forever. Food is medicine. We have a mantra: food is my medicine. There's no excuse for not taking my medicine. I take it 3 times a day, whether I feel full or not, whether I feel fat or not. No excuse. Food is my medicine. So much a part of recovery. And then supports being a very important part, I think, of all treatment of eating disorders, but specific to TBT, supports are needed and a necessary part of treatment for both adolescents and adults. That any of the outcome data certainly supports the fact that the prognosis is better if you have supportive, healthy, supportive others that are going to be available to you to support your efforts in recovery and very much want to be a part of that. So this is Pooh Bear in his wisdom. When making an expedition to discover the North Pole, be sure someone in the group knows what the North Pole looks like, and it's sure to be a pole stuck in the ground. So I think we need to define temperament and character before we go any further. I want to give credit to the person who designed the instrument that I've been using since 1994, which is the Temperament Character Inventory. I think for individuals in private practices or in practices where you do not have access to doing psychological testing, that this information from this presentation can also simply be used in your individual work. You don't have to be using an inventory to determine a person's temperament and character. Over the course of your work with the individual, you're going to come to understand the outstanding features of their temperament, the way they lean into the world or lean away from the world. You're going to come to understand those things that have been most influenced by the environment and their character structure. However, I like the TCI. I have, at this point in my career, given hundreds upon hundreds upon hundreds and done hundreds upon hundreds and upon hundreds of interpretations, and just feel that it's very, very valuable. Because we work in a PHP, a partial hospitalization, and we have the patients for a discrete amount of time, this is a way to facilitate understanding the temperament of our individual patients a little more quickly than it would take working with them once a week on an outpatient basis. Why use the TCI? Well, there's been considerable research. The very first article I read about the TCI was published in 1993. And then we have used it in all of our fMRI studies over the last 11, 12 years. Let me talk a little bit about what Cloninger means about what is temperament. Why can't we just use the word a person has a personality or a personality disorder? I like the TCI because of the breakdown of the hardwired temperament traits and then the character, which will change over lifetime and represents more of environmental influences upon the expression of who we are. So temperament describes what grabs our attention and how intensely we respond to it. My sister and I could go into the same situation, and I can promise you that our temperaments are so different that we're going to walk away and we're going to have completely different responses in terms of what caught our attention and how intensely we experienced that which caught our attention and how we responded to it. Now, character describes those aspects of the self that are learned by your experiences and your response to the environment. And that certainly is going to change with stages of life. I'm not going to respond to a situation the same at this stage in my life that I would have when I was in my 20s, because we constantly are changing and our response and attention to things, you change. I'm not going to want to do, I'm just kind of past going out to nightclubs. And that was something that certainly was appealing to me at one time in my life, and no longer fits. So I think we can all think of things that represent how the environment influences us and we change over the course of time. And then we can identify things that have remained the same about me, probably from early in life. Character scores reflect, excuse me, how individuals manage the emotional drives emanating from their hardwired temperament. Okay, so I will just use myself as an example, since I'm the only one sitting here in the room, that I'm a highly avoidant individual. So I would tend to have a lot of anticipatory worry. So what I've learned to do is to do a lot of self-preparation before going into new situations, in order to kind of manage that aspect of my temperament so that I don't completely avoid things that I might be interested in and want to do, but find myself a bit anxious, like this presentation. So I'm not going to spend a lot of time on this, but just to familiarize you with the TCI. It has 240 items. These scales that measure temperament, so you have the novelty seeking is the primary scale, but then it has subscales. And I find this to be, I find this to be very, very valuable. So when I'm doing an interpretation and a person scores really high on novelty seeking, I'm going to want to look at these subscales and I'm going to want to know what's pulling that subscale up. Do they have high percentiles on all of these subscales, or is the subscale of impulsiveness at the 90th percentile? And maybe extravagance is only at the 40th percentile. So in my work with that patient, I'm going to focus more on the impulsiveness that drives the novelty seeking, because that means that that person, in trying to do new and different things, because that they find that appealing, that they may do that in a rather impulsive way, and that could create difficulty for them. But how can we then take that temperament characteristic of novelty seeking and have it work for them in recovery? Because this is a person that is probably not going to be suited to working in a factory on a line. They're going to get bored very easily. They need new and different things. And so they would make that consideration in order to be successful at a job. Harm avoidance. When you break those subscales down, there's anticipatory worry, fear of uncertainty, shyness. These are the subscales. If the person scores in the 90th percentile on shyness, but maybe only in the 20th percentile on fear of uncertainty, then within our creating a treatment plan and looking at some of the things that might be difficult moving forward in order to recover from an eating disorder, we know that recovery is very much about connections and healthy connections. And if a person's incredibly shy, that's difficult. So that's something we're going to want to focus on. I didn't do all of the scales. Another scale that comes up time and time again, particularly with the restricting anorexic, is a very high score on persistence. This is an example of an Olympic athlete that we treated here some time ago. She scored 96% on ambitiousness and 80% on perfection. Now, if you take those scores and if you take those temperament traits, and if she's able to move them from supporting her eating disorder, her anorexia, persisting and trying to perfect being the best anorexic, and you move that toward her sport, then that's going to very much be a very positive expression of that temperament and help her sustain recovery. The character scales, and once again, these are the ones that change over a lifetime, are self-directedness, cooperativeness, and self-transcendence. I'm not going to go into this. This is more of a breakdown of those scales. So these are generalizations, but they are founded in research studies in terms of what is most often the key temperament of the anorexic, the pure restricting anorexic. They typically score high on harm avoidance. They tend to score high on obsessionality. They tend to be highly anxious. They score high on reward dependence, high on perfectionism, tend to score very low on novelty seeking. So this is the individual that if I can't predict outcome, if I don't know that I'm going to do something perfectly, if I don't know how to do something, then just don't do it. So this is the area that we work on, because with that, then once they have something like anorexia nervosa, which gives them a set of rules to abide by, then it's very difficult for them to step out of that and take risk doing other things in life that maybe there aren't rules to follow. And then they have abysmal self-esteem, as do the majority of individuals that we treat with eating disorders. Temperament and bulimia. This is kind of mixed. Now, this actually looks more like anorexic binge purge type and bulimia nervosa, where you find these characteristics. They may or may not be high on harm avoidant. They typically are obsessional, perfectionistic, anxious, low self-esteem, very similar to the anorexic, except for that we tend to see much higher scores in novelty seeking. And it's interesting, if they have high novelty seeking and high harm avoidant, that's where the conflict is. They're anxious and worrisome. They get ahead of themselves, what we call future tripping. They're nervous about doing new and different things, but they have a very strong drive to do new and different things and to take risks. So they often are very conflicted about that. And that's an area then to focus on in terms of how do you use the caution that presents itself with somebody that's rather avoidant, and yet how do you use the risk-taking in order to allow them to engage life without having to override their harm avoidance by drinking or using drugs in order to satisfy that aspect of their temperament. Tend to be more impulsive and tend to have more affective dysregulation. Temperament in our binge eating disorder patients, and once again, as I say, we do research on this, and so we've looked at hundreds and hundreds of these, comparing the different subgroups on their TCI scores. They may be high on harm avoidance, highly impulsive, sensitive. All of our patients tend to have a high level of sensitivity, low self-esteem, lacking purpose. Now that's the self-directedness score on the TCI. where we have patients that have very, very, very low scores on self-directedness, something we want to focus on in treatment. That is that they lack meaning and purpose in their life. So then the eating disorder comes along and it gives them meaning and purpose. It begins to define them. It gives them rules to follow, something to get out of bed and do every day. And when you take away that eating disorder, or they give up that eating disorder, very often it's like, well, what am I going to do? How do I organize my life? What's going to be my purpose? So very important area to work on when you see very low self-directedness scores. So what does treating the traits mean? Basically, we all do this. I don't know that we say we do this. Specifically, I do because of using the TCI. And I think with the new temperament-based treatment model, that we'll probably be using this language more for those who are interested and decide to pursue working in this kind of within this context. To change, you must practice that which is non-dominant. So we get grooves in our brain. We develop patterns of behavior, very easy to slide into those grooves and just do things as we always have done them. And with an eating disorder, we are trying to affect change. We don't want our patients to continue to do what they've done that supports their eating disorder or any other psychopathology. So we have to practice doing that which is unfamiliar and uncomfortable. If somebody told me I had to brush my teeth with my right hand every morning, it would be uncomfortable for me. I think over time I could probably learn to do it, but it would just be easier to go back to using my left hand. An example I might use with my patients, because we can't just tell them, don't do that, do it this way. We know that doesn't work. Just stop doing that, or, you've got to break that pattern, so do this. I think we have to kind of sneak up on it sometimes, and we have to start with just small things. We introduce the concept that we have to practice doing that which is non-dominant, but then we start with things like, tomorrow when you drive to the clinic, I want you to go a new direction. Now, for some patients, they may have to just visualize that and imagine going a new direction before they can get to the point that they can actually do it, because it's just so uncomfortable. Secondly, the message we want to give to ourselves and our patients is we want to make the best of what we have. If this is your temperament and these are the outstanding traits of your temperament, let's make the best of it. Learn to constructively manage your traits. This is you. You are your responsibility. The more you know about yourself and the more you accept yourself, then we can constructively use those temperament traits and those characteristics of who you are. What we do know is that when good traits go bad, you have illness. But when they go good again, you have recovery, and you can sustain recovery. And this is hopeful. This is so very hopeful. So again, and I'm going to say this over and over again, we want to leverage and capitalize on the positive potential of our traits. When we used to do write-ups, I pulled out a write-up from like 2005 that I did on the TCI. I was so struck by the fact that I described this individual in all of their temperament traits and characteristics, but I described them in a manner in which it made sense that the person developed an eating disorder and how these traits were sustaining the eating disorder. But there was nothing about how to positively use the potential of those traits. And that's the beauty of what's changed in our field in terms of really being able to, I think, affect change by understanding the temperament and character of our individual patients. So these are some examples from the book that's coming out in 2021. And there's many, many more. I'm very excited about being able to use some of the work that has been produced by this group. So if an individual has intolerance of uncertainty, So these are the individuals that, ooh, I don't know. I don't think somebody invited me to play pool, and I've never played pool before. And so I don't think I'd probably be very good at it, and I'd get embarrassed. So I just won't do it. So there's just this, and we see it with our patients all the time in terms of, oh, I don't eat that food. I'm afraid I'd like it, and I'm just not certain, so I'm just going to avoid. So with real high levels of intolerance of uncertainty, what we want to do is, we can't make that go away. That's part of their temperament. So what we can do in treatment and what we can actually help them learn to do in their life is, to the best of their ability, increase predictability. And we do that in our programs. We really try to start our groups on time. We start our meals on time. They know what the rules are during mealtime. They can't get up and get a glass of water. But having these rules for people that are rule bound gives them a sense of security. We simply want those rules to be healthy and to sustain health. That leads into the next one. Great deal of overlap here. People that are very rule bound. So use treatment rules. Use rules that are going to help the person move into a healthy set of rules rather than rules that sustain the eating disorder. So we have a rule of no laptops and phones, and of course, nobody wants to turn in their phone. But what they find is when they abide by these rules, they can be more fully present during treatment. So we do give them rules, and very often give them rules for the individual that we think is going to work for them as they leave treatment. And that for one person might be a meal plan. Many of our patients need to leave treatment with a meal plan and stick to that meal plan for a while because they're very rule bound, and it's a meal plan that's going to help sustain their health. For individuals that are highly obsessive, we're not going to make that go away. You can't talk someone out of being obsessive. They have a great deal. There's some real benefits to that in terms of attention to detail. So we give them very detailed oriented recovery plans. We have them create a relapse plan. We have them, create a treatment plan. Our patients that are high in obsessiveness, when we go over their treatment plan, they want a copy of it. And that decreases anxiety that they feel with regards to needing to know things and needing to know the details of things. People that are very achievement oriented, once again, we're going to leverage treatment rules. They want to go, we have a level system here. People that are achievement oriented, they want to get from, and it's based on the ski slopes. So they want to get from green to blue to black to double black to double black diamond, and they want to move through that. But in so doing, they are doing the things they need to do in treatment that are going to help them learn the skills they need to sustain recovery. So I had an opportunity to do a workshop at the 2020 Academy of Eating Disorders. And this was one of the scarier things that I did in my actually 42-year career. I think the bio must be a little dated. So this was the group of individuals. This workshop was focused on childhood traits that may be viewed as risk factors for the development of eating disorders, but may also facilitate positive outcomes in recovery. People in the eating disorder field who have had eating disorders discussed the traits they had in childhood that persisted after their eating disorder recovery and how these traits have helped them succeed in life. So each of us that were on this panel was asked to choose a particular trait and describe how it worked, how it may have led them to a vulnerability to develop an eating disorder, and then how it served them in recovery. So this is the first time I stood up in a public forum and told any of my story. In my early years in my career, I would have felt that this was professional suicide. And it's not something I share in my work with patients. So given the fact that I chose inhibition, I was quite nervous. But I am going to share with you my story, and hopefully that gives you an example of the work that you can do. And I think that's very valuable to do with your patients. This is the story of what traits made me vulnerable to the development of an anorexia at age 15. It's the story of what I had to do to find 50 years of sustained recovery. And it's a story of how I leveraged the positive potential of my temperament to benefit of not only my health, but the health of my patients and the health of my children. So I believe my story of inhibition and low risk taking actually starts at a very, very young age, certainly years before the development of anorexia nervosa. I was not born into a generation defined by the cult of expression or the endless need for an audience. Being born in the mid 1950s placed me at a time when young girls were still seen but not heard. And my mom and sister already owned all of the real estate in our family related to histrionics and emotional expression. I had a supporting role in my family as the daughter who was shy and self-conscious. I particularly like the definition of inhibition as a mental state of hesitation. Obviously, I cannot speak to any unconscious curtailment of a process, but I can recall early efforts of both physical and cognitive inhibition. I can recall many ways that I tried to prevent the development and the manifestation of certain drives and impulses. They were scary to me. Now, my sister loved to get me on the ground and tickle me. She was my older sister, and she tickled me to the point of tears. We know tickling stimulates the hypothalamus. So I engaged, and I can remember this very clearly, in a conscious practice of attempting to override that hypothalamic homeostatic signal. Now, at the age 6, that's not what I knew what I was doing. I would just simply get inside my head and I would repeat to myself over and over again, I'm not ticklish, I'm not ticklish, I'm not ticklish, until she just stopped trying. This reduced my emotional anxiety as I was somehow able to cognitively recruit my inhibitory control network, and it completely manipulated my body's physiology to not respond. I was able to filter out undesirable stimuli. My next memory of an effort to engage in mind over matter occurred every Saturday morning for many years. My father would drive me to violin lessons. After these lessons, I would walk to the old limestone library. I would climb the stairs, open the door to the smell of limestone, wood floors, and books. And I would immediately become anxious and have to go to the bathroom. I now believe this happened for two reasons. One, I would always think, how in the world am I going to read all of these books? And two, I hated going down into the damp basement of this ancient building to use the bathroom. Now, whether I engaged in cognitive inhibition or physical inhibition, I began the process of tuning out this urgency. In fact, I could go all day without needing to go to the bathroom. And it's still one of those things to this day that I have to remind myself to do. And it feels like a form of kind of refined form of sensory gating. And I think our patients do this around hunger. As anorexia nervosa became an insidious and pervasive part of my 15-year-old world, it wrapped itself around my inherent shyness and cognitive and physical inhibitions. It was very easy for my anorexic-informed beliefs to convince me that my body, my desires and drives were wretchedly inadequate and even revolting. I would say I became the poster child for a better living through deprivation. Looking around me, my mother was physically and emotionally too much. There was nothing disciplined or contained about her or my sister. I chose then to emulate the very reserved, quiet, planful, and orderly style of my father. Our temperaments matched. The discipline required to maintain the increasing rituals and rules of anorexia was, to me, the perfect rule bound way of being in the world until it wasn't. So, upon the awareness that this was truly hurting others, specifically my father, and would interfere with my ability to go to college, the question became, how in the world do I get out of this? It feels so natural to me. It fits my temperament. How do I stop making it make sense? Although not feeling hungry, I have to eat. In other words, I have to learn to override my fears and inhibitions. Initially, I kind of overshot my efforts, and I know a lot of our patients are afraid of this. If I eat one donut, I'm going to be the size of this room. Um, if I take one drink, I'm going to be drunk. Just that fear of from over control to out of control. And I did overshoot a bit, and I think I made some choices that were a bit scary. They were a bit fun, but potentially dangerous. And ultimately, as I think about it over time, they just were not in line with my values. My venture from over control to out of control was really relatively short lived. I had to find a way to be true to myself, but not let my inhibitions stand in the way of expressing myself. I had to find a way to become relatively more comfortable with self disclosure, still awkward, a way to try new and different things because I was curious. I was just avoidant and anxious and fearful. And to more actively engage friendships, work, and life. That's the connections piece. Um, I had to discover that by inhibiting the expression of my scary drives and impulses and desires, that anorexia also robbed me of the gratification from pleasurable activities. Now, our patients will often claim they don't care, that pleasure is frivolous. But the truth is, it just renders them joyless. And we have all sat in the room with anorexia nervosa and how joyless it is. So, how did my childhood trait of inhibition and risk avoidance facilitate any positive outcomes which have helped me sustain recovery? Number one, I discovered if I was going to be effective at all in helping inhibited, cognitively rigid, worrisome, perfectionistic patients, then I couldn't fake it. I would have to either override temper at the very least, or figure out how to utilize those traits in myself in a manner that was healthy and could model recovery. I have a lot of examples of that, but I don't think I have time to go into it. Certainly, we can dialogue via email if you want to. Secondly, I met key individuals in our field. I am sure all of you sometimes sit with your patients and go, ooh, if I could just match you up with this type of person that would help kind of bring you out and bring you back into life with some meaning and purpose. You want to play matchmaker a bit. But I met several key individuals in our field that were determined to physically and psychologically kind of push me out of my comfort zone. So one convinced me to share the stage with her at the first national conference I spoke with, which practically dragged me on the stage. One joined me in the task of designing, developing, and running an eating disorder program, my lifelong dream. So I soon learned to gravitate toward people who were less inhibited than me, slightly greater risk takers, and those who would add color, dimension, and texture to my world. I believe I slowly became extroverted introvert, at least in their presence. I also discovered that forever part of me that is still inhibited has actually served me well as an administrator, a supervisor, and a clinical director. I am not reactive when chaos abounds. I take my time making a decision in a very planful, methodical way, and I can ward off distractions which helped me to effectively focus on the task at hand because of my attention to details. Without the use of starvation, I can still protect myself from sensory overload. Now, coming to the end, I chose this picture because it represents so much that I've just described in my efforts to redirect my inhibitions. I took to the stage at a national conference with my daughter, Brogan, there in the middle with my granddaughter, Leo, and Dr. Michael Levine, to explore whether we can identify protective factors that allowed my daughter to get 50% of my genetics and to be predisposed to the development of an eating disorder and yet not develop an eating disorder. We compared our TCI scores, we looked at our brain scans, we examined our individual temperament and character, we explored the epigenetic landscape of navigating developmental challenges as she was growing up, as I was growing up. We explored how to use the strength aspects of the temperament traits to achieve and maintain recovery for me and my patients, and for my daughter, how she used aspects of her temperament to avoid developing an eating disorder regardless of the genetic loading. So what's the conclusion? Considering the context in which our patients' temperament traits may be adaptive and shifting toward considering the positive elements of these traits within and outside of treatment could enhance outcomes and decrease stigma associated with eating disorder. And for that, I am so very grateful and so very excited in terms of the direction this is taking our field. Thank you very much.
Thank you, Dr. Pryor. That was wonderful. Thank you for sharing some of your story too. So for everybody who, please add questions to the Q&A, and we'll get started off with this first one. Dr. Pryor, somebody is wondering how private practice providers can get access to the TCI. They mentioned that they've looked, but they've had no luck.
This would be something that, I ordered my first TCI in 1994, and we have it downloaded on a computer so that the patients can just get on the computer and take it, and we get a scored version from that. And so I will look into, because I purchased it so long ago, I don't know what's current, but I will absolutely find that out. I know the research group that I collaborate with have gotten updated versions recently. So if you could give people my email address, then I can send that information.
Of course.
In terms of how to get the manual and actually how to get the instrument itself.
Okay, I'll add your email address to the chat right now so that participants can directly reach out to ask you about the TCI. Another person wants to know if it's required to have a doctorate degree to administer the TCI.
No, it's not. Unless the individuals who now own the TCI, if it's not still owned by Washington University in St. Louis, have sold it to a company. I know that there are restrictions that have been placed on some instruments in terms of you have to go through a training or you have to have a certain level of competence or degree. We have used the TCI here for years. It's very, very easy to administer. We have certainly had people with bachelor's level, master's level, PhD level in terms of their training administer the TCI. And you can, and I think anyone can learn to interpret it. It just takes time and practice like anything else. So.
Okay, and then do you have any other guidance on interpreting a TCI that you can share?
I have worked up a little cheat sheet that I like to use.
Okay.
That I certainly share with anyone, where I broke down high scores, mid scores, low scores, and then written kind of an interpretation of that. And had used it in the beginning. I had to use it to kind of help me talk individuals through. It's so familiar now to me that I can pretty much guess what somebody's TCI scores are going to be after I've met with them a few times. And I think we kind of make a game of that in staffing, and that we're all sitting there going, does anybody want to guess if this person scored high on, harm avoidance, or this person is high on novelty seeking or low on persistence? They give up on things easily. That we do that in staffing. But I can also make my cheat sheet available to anyone that's wanting to explore using the TCI. I really, really want people to know, though, that you don't have to use this instrument. I love this instrument, but I think the workbook that's going to come out along with the book on temperament-based treatment is really going to give you the tools that you need to start maybe including this in the work that you do with your patients. But once again, I can send any of the material that I've developed over the years to help me with kind of learning how to use the TCI.
Thank you. That cheat sheet sounds wonderful. Are you able to provide some examples or experiences when giving feedback to patients about their TCI results, and how do practitioners do so in a strength-based manner?
I think how I introduce it is very much how I used to introduce. I used to use the MCMI a lot. I'd look at the MCMI and think, how in the world am I going to tell this person that their highest score is narcissism? And only to find out that they usually like that. That I was uncomfortable, but the patient hearing that wasn't at all, or that they scored high on borderline. So I do start with some of what I've used in the presentation in terms of that, that this is a way that you're going to be able to learn things. You're telling me who you are, and I'm going to describe that back to you. So it shouldn't come as a surprise. And I'm going to describe it to you in a manner in which we're going to focus on how we're going to help you here in treatment to have your temperament traits work for you rather than work for the eating disorder. And so we're going to talk about what are some of the benefits of having a high score on harm avoidance. When does it get in your way? When is it in service of the eating disorder? Or when does it work? Because a person who's high on harm avoidance, they are not going to get eaten by the saber-toothed tiger. They're going to be very cautious. They're going to scan the world around them and make sure that they make very safe decisions. Now, it may be so extreme, the score may be so high that they're not making decisions at all. So we do want to talk about how can we begin to take more risks, but they're never going to become risk takers. They're never going to become high scores on novelty seeking, but we can begin to look at how harm avoidance is such that they're holding back and they're keeping themselves from doing things that they would really enjoy doing. I start talking with them from the very beginning in terms of how the certain characteristics and we look at the main temperament trait, and then you look at the subscales. I'm going to emphasize on how we're going to work to decrease the shyness. They may always be a shy person, but what can we do to decrease that shyness and in an effort to be able to feel more connected and have more relationships and feel like you can get comfortable with yourself within that relationship. So I could get hundreds of examples of this. Somebody that's very low on persistence give up on themselves easily. So I don't say, you just don't follow through on things. I'm going to say, we're going to work on increasing your ability to be able to follow through, because this is getting in your way. You're procrastinating. You're not doing things. You're not doing the things you want to do. What kind of skills can we build in order for you? We're not going to go from no persistence to extremely high persistence, but we can begin to use, you might use another person. If you have a hard time sticking with something, then maybe you have somebody that you know who is high on persistence and you can connect with them. That's the person that when you in school are told you've got to do a project, It's the one individual in that group that does the whole project. So you find that person that's going to help you, it kind of enhance that particular trait in a more positive direction, so that that it's working for you in a more favorable way. Hopefully.
Thank you. To jump right into another question, you're answering these so beautifully. Somebody said, excellent presentation, Dr. Pryor.
Oh, thank you. I just can't see these smiling faces or head nodding.
Everybody is nodding their head and smiling, I'm sure of it. They say, thank you for approaching your anxiety to share this information with us, and that you mentioned two of their favorite people, Dr. Laura Hill and Dr. Michael Levine. And this individual is curious how the gift of emotional sensitivity that Dr. Anita Johnson writes about in Eating of the Light of the Moon, so depth of emotion, reading between the lines, knowing how others feel, common in those struggling with an eating disorder, might relate to temperaments common in eating disorders.
I think on one of the slides describing TCI scores in one of the subgroups of eating disorders, certainly that sensitivity descriptor was there. And, I had a person just tell me that, that they grew up, and I think Anita Johnson does talk about this. I haven't read the book in many years, but I love that part of the book and the way she described the value of being sensitive. But unfortunately, so often the message we receive when we're young, or many people do, is you're just too sensitive. And that always just kind of drove me crazy in terms of how can a person be too sensitive? Because being sensitive is just having such a heightened sense of awareness. And I can see, particularly when a person is struggling with an eating disorder, how this sensitivity can be agonizing and cause them distress. And so I think it is very important in therapy to begin to talk about the beauty of sensitivity, that you're going to be aware and pick up on things that other people are totally clueless about. You're going to go outside and you're going to see colors. You're going to notice things that other people don't notice. Now, when you take the things that you are sensitive, you have this hypervigilance, this high level of sensitivity, and then take on other people's experiences and feel responsible for them, then that we have to work on, in terms of, let's use that strong gut you have, that heightened sensitivity and awareness of the world and environment around you, that sensitivity to what's going on in other people's emotional worlds. But let's put some boundaries on that in terms of not making that your own. The awareness is powerful, but you don't want to personalize it and make it then your responsibility in terms of taking care of the needs of others. My patients are so sensitive to whether I glance off to the corner, if I cross my legs, if I lean forward, if I lean back, they're picking up on everything. And I have to check in with them in terms of what kind of assumptions they're making, because I know they've got that sensitivity. And we do talk about, how to use that in a positive manner, in a strength-based manner, and ways in which it can create more anxiety and distress. So that was a long answer.
It was a long question, so.
It's a big question, it really is.
A lot to unpack there, and I think you did a beautiful job. So for the last question, would you remind our attendees the name of the book that you mentioned earlier about temperament-based treatment?
I'm going to go back so everybody can get that, because I'm very excited about that as well.
Wonderful. Thank you.
Absolutely.
And as a reminder, everyone who's joining us, we will send this presentation out, a recording of it, probably early next week. And we will also have the evaluation. It'll pop up as soon as you close out of the webinar. Please fill it out, and we'll also send the webinar or the evaluation form. We'll send it out in an email next week too, in case you don't have time to fill it out. Maybe you have a session coming up. So thank you everybody for joining us, and jot down the names of these titles. And we're really looking forward to these pieces coming out.
And please, please do not, don't be shy. Easy for me to say. In terms, I'm pretty good on email. So please, if you want more references, if you want any of the materials I have, if you have just questions that come up going forward, I'd love to dialogue with people about this. It's a little lonely out here just kind of talking to myself. So.
Well, thank you so much, Dr. Pryor.
Absolutely.
Thank you everyone for joining us, and stay tuned for that email. Have a good one.
Thank you.